Hello, my name is Dr. Laurel Kaufman, and I am a pediatrician at Weiss Blue Pediatrics in Chicago, Illinois. I am joined today by Dr. Nancy Kuntz, Professor of Pediatrics and Neurology at the Northwestern University Feinberg School of Medicine in Chicago. Welcome, Dr. Kuntz.
Hello.
And by Mr. Filippo Bucella, founder of Parent Project APS and an advocate for patients with Duchenne muscular dystrophy from Rome, Italy. Welcome, Mr. Bucella.
Hello.
In this section, we will be considering the question, what are the key signs and symptoms of Duchenne muscular dystrophy? Duchenne is a severe progressive muscle degenerating disease and the most common form of muscular dystrophy. In my clinical practice, I've only seen a handful of patients outside of residency. But for Dr. Kuntz, what is the prevalence of Duchenne muscular dystrophy? And what are the potential factors that may increase a child in developing DMD?
As this is a genetic disorder linked to the X chromosome, it's symptomatic primarily in boys. There are very rare carriers who are women with symptoms, but our discussion today is about the common form, which is really limited to boys and men. They estimate 1 in 3,500 live births in male infants may have a mutation in this dystrophin gene on the X chromosome. But one of the most complicated parts of detecting this early is that the symptoms are very limited in the newborn period and very difficult to detect. And this is a very large gene that has a very high rate of spontaneous mutation. So about a third of all of the children with Duchenne muscular dystrophy that I've seen have not had any family history. And so then without any family history or any reason for the families to suspect that there might be something going on in the muscles of any of the boys born into the family, it becomes much more difficult to diagnose early on. And then when the symptoms develop, they develop very subtly, I think. And we have this combination of the very gradual onset of muscle weakness superimposed on the normal development and maturing of the central nervous system and new skills that a child might have. So a child with Duchenne will gain motor skills, but they tend to do it a little bit more slowly and a little bit differently than their peers.
Sure. In one of the most recent patients I had seen an 8-year-old who had presented, hasn't seen medical care for a few years due to the pandemic, but at that point had already shown severe progressive delay, was physically struggling to walk, was showing me himself his Gower maneuver of pulling himself up his legs. Generally, for these younger patients, for the newborns, for the babies, I mean, what are the non-motor and non-neuromuscular symptoms that clinicians such as myself should be aware of for DMD?
Very honestly, in the newborn period, it's very, very difficult to detect any differences. But as the children become toddlers and begin to stand and learn to walk, you can see some subtle changes. Frankly, some of the earliest changes we see are non-motor. There's an increased incidence of executive dysfunction problems, with focus, organization and attention, some verbal learning disabilities, and an increased frequency of autism and autism spectrum within children who have dystrophin mutations. So I think any kind of general delay like that should, with a primary provider, raise a question about would it be appropriate to screen for a Duchenne with a CK, because that's a relatively less expensive diagnostic test that could be included as other things, chromosomal microarrays and other things like that are done to try to evaluate just general problems with overall cognitive and social development. The two other things that I've seen that might make a difference to primary providers is a short stature, shorter than the siblings. And then the final thing is unexplained elevation of liver enzymes. So if the ALT and AST are elevated without the GGT being elevated, sometimes that launches a very large GI workup. But in fact, if the GGT is normal, very important to remember to get a CK. There may be other specialists involved by this point in time, but even all the primary providers, you want to think of getting that CK because that tends to be quite strikingly different in toddlers and school-age children with Duchenne. And then that leads us directly to be thinking about the dystrophin deficiencies.
Now, Filippo, your son was diagnosed with Duchenne muscular dystrophy at 3 years old. Before his diagnosis, what were the signs and symptoms that indicated he might need referral for further investigation?
Well, I must confess, we didn't see any sign before because we were noticing a little bit of weakness, but nothing that could really worry us. Going back after we got the diagnosis, if I go back now and think about that time, I can say that probably when he was just an infant, he was probably less mobile, as you say. He used to sleep on his back, not rolling, and that was one of the things. And indeed, Luca was our first son, so we were not used to notice differences because we didn't have any we couldn't compare with anyone else apart from the kids at school. So it was easier maybe for the teacher, for the people at the school to notice something when he was so young, but we couldn't notice anything. When we had the second one, Giacomo, and it was something like 17 months after Luca, we immediately realized that there was something wrong, but Luca was almost 3, so it was the time to go. Because Giacomo was jumping everywhere. Luca was a very quiet and reflexive boy. He used to read, to be very quiet, so we were not able to see any difference.
Clinically, where I practice, how we work in the United States, if we see a child with any types of developmental delay of their physical skills, we typically refer on to a program early intervention where they get a full evaluation. What was the initial referral pathway for you? What was that experience like?
So we started to notice, as I was telling before, that he used only one leg to climb the stairs. So this was the first thing that made us kind of, weird. Then he was very suffering at night because he couldn't breathe. And so we were trying to understand the causes of this situation. So he had a very important adenoid situation. So he had to undergo tonsillectomy. And so we did all the tests and we noticed that he had 11,000 CK. And that was the first ring that sent us to the specialist. So we did a biopsy and then we moved on.
Sure. And obviously after this diagnosis, how has this impacted daily life for you?
Well, it's a kind of terrible situation because you see a healthy boy because he doesn't have any other symptom, but you already hear to the situation that he's going to face in a few years. Because when Luca obviously had his diagnosis, it was 28 years ago, the world was a different one. Now we have a different situation, so we know we can have hopes for another 20, maybe 30, maybe 40 years. At the time, it was quite serious because we know he was risking his life when he was 14, maybe.
Sure, of course. And your experience with the whole multidisciplinary team, how has that worked for you?
Well, the multidisciplinary team, even now, even in the best center in town, is not 100% guaranteed. So we're still working to have everything smoothly going from one to another. Sometimes in an hospital, you are not able to find everyone. So you need to run and through one hospital and the other. So it's not so easy. But obviously, that would be the perfect situation.
thank you both for Dr. Kuntz and Mr. Bucella for this interesting discussion, and thank you for our audience for listening.
Hello, my name is Dr. Nancy Kuntz, and I'm a professor of pediatrics and neurology at the Northwestern University Feinberg School of Medicine in Chicago. Today, I'm joined by Dr. Nadia Merchant, who's a geneticist and endocrinologist at Children's National Hospital in Washington, D.C. Welcome, Dr. Merchant.
Thank you. It's my pleasure to be here.
Wonderful. And we're also joined by Mr. Filippo Bucella, who is founder of Parent Project APS and an advocate for patients with Duchenne muscular dystrophy from Rome, Italy. And most importantly, a parent of a boy with Duchenne muscular dystrophy. Welcome, Mr. Bucella.
Thank you, and hello, everyone.
In this section, we're going to be discussing the issue of what the key considerations are for the diagnosis of Duchenne muscular dystrophy, and then also consider some issues of pre-symptomatic screening for the condition. Duchenne muscular dystrophy is a disorder that has been difficult over the years to diagnose in young children because the symptoms are relatively nonspecific and mild in the newborn and toddler years. Also, at least a third of the families where Duchenne appears experience it as a de novo mutation, meaning that there's no family history or no previous experience of the disorder for them to use as a guide to detect early problems. So given this, Dr. Merchant, how would you have people approach the issue of diagnosing Duchenne muscular dystrophy once there's a suspicion?
So once there's a suspicion for the diagnosis, sometimes a lab work can be very helpful. So getting a CK level or getting unexplained increase in transaminases, so like ALT and AST could help you maybe suspect the diagnosis. Obviously, if there's a family history of Duchenne muscular dystrophy, then you're thinking of it. But if there's no family history, then the child may be having the Gower sign or toe walking they may be having, and then they may be not completely walking by 16 to 18 months. Sometimes some delays, motor delays that may be progressively happening. So initially we start off by testing a CK level, and often it's not the neurologist that's doing it. Sometimes the pediatrician checking it or somebody else that is checking the level. If the CK level is not increased, then it's unlikely to be Duchenne muscular dystrophy. If the CK level is increased, then you will proceed with testing for it by doing the DMD gene deletion and duplication, like genetic testing for it, to determine if there's a known mutation that exists. If there is not a known one, then we can go further into testing. There's a lot of other ways to go further into testing because not all the variants are easily found, so that's why, because they're not as common. But I think the main thing is getting the CK level to help you determine if it's DMD or not, possibly, and then going to genetic testing to determine if that's the case. And obviously, the clinical exam has to be consistent with it. And the muscle biopsy is often considered, especially when they're not sure what is going on.
Oh, so Mr. Bucella, I'm wondering if you can provide us with some perspective from the community and the family point of view. Do you think there's anything that we need to do communication-wise between the families and the primary care providers around this issue of suspecting that there's something wrong?
Well, it's not easy because if you're not expecting something, you're not looking for anything. So it's quite
there you go.
Especially in family, as you said, with de novo mutations. I feel that talking about this kind of diseases should make easier for all the community to learn in advance. So probably we are, as association parent groups, are working with the schools, are working with the typical people that has to deal with our kids, so that we can teach them to recognize their symptom in advance. So we are trying to work together with a lot of associations of professionals so they can help us to set up some alarm rings We are also in Italy, at least, we're working with the family pediatricians so they can set up like a health balance and they can check in advance the CK, because as you know, we don't have in Italy a newborn screening, and there is a lot of discussion regarding the usefulness of doing the CK screening. I tell you, in my experience, I've been speaking with family pediatricians and with families, and both the protagonists were very worried about talking about Duchenne because they don't have a cure as a pediatricians, and families continue to think that maybe they were happier when they didn't know about it. So it's quite a weird discussion. So I think that if we are able to involve a lot of different professionals to help us to put down the age of the early diagnosis, I think we've done the best thing we can do.
Right, because the kinds of things that parents notice and tell me about, difficulty getting up off the floor when the kids are playing on the floor, or in preschool sitting for circle time, difficulties with the stairs and things like that. There can be a number of different things causing that. And many times with it being a boy, people try to be patient and give them time to catch up. But I guess I've also been impressed, not only at that level, but at the school age level, how the children would prefer to not complain. They try to minimize any difference that they have. And that's why sometimes we find ourselves diagnosing the problem only at age 6, 7, or 8, because the child is awkward or a little bit socially awkward or a little bit delayed, and people, don't press the issue. But here we have things that can be done to improve outcomes, and that makes it important to try to catch it early. I know, Dr. Merchant, you were discussing some of the logical points in terms of making the diagnosis. Do you have any other thoughts about the logical steps for pursuing the diagnosis there?
So I guess if you have the other question is really, should we be doing newborn screening for Duchenne muscular dystrophy? And that's been a big discussion. There've been some small pilot studies that are being done around the world, really, to see are we going to have a lot of false positives? Because I really don't want to give a family a diagnosis and we don't have one. But also, how do we navigate the system if we do get a positive at a baby, which is asymptomatic at the moment? So there's a lot of work currently being done to determine whether or not how to do newborn screening and how do we go about it. But I think the main thing is really educating the pediatricians and the healthcare providers in general on how do you diagnose earlier, and then also referring them to the appropriate place sooner. Because I think what's really disappointing is when I'm part of the muscular dystrophy clinic and I have a child coming in at the age of 11 for the first time, or the 10, and then you wish that you had seen them earlier. And there could be a lot of different reasons for that. Maybe the family knew there was a problem, but they didn't want to embrace it, and they were just scared to go to the doctors. So there's a lot of different obstacles along the way. I think it's easier for us to say, let's get labs and diagnose them and get the genetic confirmation test. But I think we need to work a lot on getting them in the right direction. What do you think? Right. Because you see these kids all the time.
Right. As a neuromuscular focused physician, I can say that there are changes ongoing in the muscle from the newborn period. The muscle biopsy at age 6 months and 18 months and 5 look very different in a boy. So even before there have been enough symptoms to bring that child to diagnosis, a lot of change and injury has happened in the muscle. So from my point of view, finding out the diagnosis as early as possible and doing the things that we know to do to help them, even if it's not a cure, makes a lot of sense to me. Mr. Bucella, can you give us a little bit of perspective from the community and family point of view about?
I completely agree with you.
Yeah.
The cure for us family doesn't mean a pill that we can give to our kids. But if we know in advance, even at just the 2 years old or maybe 1 year and a half, you are able to reorganize your life, because many families are completely destroyed after this diagnosis. And so you need 1 year to understand exactly what you can do and what you need to do. So at least if we know it in advance, we can reorganize the families. We can work on the family group, because the family group has to manage with the problem with all their life.
Well, and also making the diagnosis, it occurs to me, also helps the family understand for themselves and the extended family what the risk of recurrence is in other pregnancies within the extended family. Do you have any thoughts about that, Dr. Merchant?
Yes, so I think we've advanced so much in genetic testing that it's really important to know the diagnosis early so the parents can plan if they want to go through any other testing for future pregnancies. And other family members may want to do that too, because about 70% or so are a carrier. Mothers are carriers for it. And I think that really does have a lot of implications from that standpoint.
Yeah, I think that, again, I know that in the United States, at least, carrier screening for this and other disorders is becoming part of pregnancy planning and pre-conceptional counseling for women, so that they can, make decisions about how to manage the pregnancy. But it all begins with the primary care individual and the parents working together to make the diagnosis and to make it early. So thank you both very much. I think this has been very helpful, and I thank the audience for your participation.
Thank you.
Thank you.
Hello, my name is Dr. Laurel Kaufman, and I'm a pediatrician at Weiss Booth Pediatrics in Chicago, Illinois. Today, I am joined by Dr. Nancy Kuntz, a professor of pediatrics and neurology at the Northwestern University Feinberg School of Medicine in Chicago. Welcome, Dr. Kuntz.
Hi.
And by Dr. Nadia Merchant, a geneticist and endocrinologist at Children's National Hospital in Washington, D.C. Welcome, Dr. Merchant.
Thank you.
So in this section, we'll be discussing what are the established methods for medical management of Duchenne muscular dystrophy, and why is a multidisciplinary team important? Now, as a general pediatrician, once a patient does have an established diagnosis of Duchenne's, I typically am a referral source, sending patients out to specialists as far as further treatment. Dr. Merchant, we'll start with you. What is the aim of physiotherapy, and how should clinicians objectively monitor the patient's progression during this physiotherapy?
So I think from a physiotherapy, you want to make sure that the patient's staying active and mobile as much as possible from a bone health perspective overall, and also following and tracking their activity level, which I think neurology does very well doing, especially once we have the diagnosis of Duchenne muscular dystrophy, what we're talking about here. But in a multidisciplinary clinic, I think that's really important that we're tracking different things along the way. So we're making sure we give them the optimal care.
That makes sense. Yeah. And this one to Dr. Kuntz, glucocorticoids are the current standard of care for patients with Duchenne muscular dystrophy. Now, I've had experience working with steroids for patients for different conditions, and definitely a lot of side effects can come along with those medications. How do you approach treating your patients with steroids, and what outcomes would you expect from this treatment regimen?
Well, the trials have shown that adding in any form of glucocorticoids on a regular basis to a boy with Duchenne muscular dystrophy lengthens their time of ambulation and their strength overall and their survival. It's important to understand a little bit about why that is. The dystrophin is a protein that helps anchor the contractile part of the muscle to the basement membrane in the muscle overall. So without that anchoring, there's more torque, and it turns out that the muscle cell membrane becomes leaky, And that leak actually creates a secondary inflammation as the CK and calcium and other things that should stay intracellularly are leaked out. And it's been shown in animal models that secondary inflammation is a big cause of muscle breakdown, not just the absence of the dystrophin protein. So using those glucocorticoids can really help preserve muscle, and that's one of the most important things in this setting. There are a bunch of different ways of doing it. People have used in the United States primarily prednisone over the years. Europe began using a fluorinated corticosteroid called deflazacort, and now that has become available in the United States. They had the tradition or protocol for many years was to use it daily, but as you've pointed out so clearly, daily steroids has a very long list of potential side effects. So some people have trialed pulse steroids, what they call the weekend dosing, meaning a large dose divided into 2 consecutive days rather than all 7 days per week. And that has, to some people's perspective, done a very good job with equal efficacy and less in the way of side effects. But again, it's newer, and so it's less traditional and hasn't been used as widespread. So it's always this issue of recognizing that the glucocorticoids do really help settle down the inflammation in the muscle, preserve muscle tissue, improve motor outcomes, but there is the payback from the side effects.
Sure, of course. And kind of getting into each component where Duchenne's can affect the body. Cardiomyopathy generally develops around the age of 10. And by the age of 18, all patients with Duchenne's will present with cardiomyopathy. Dr. Merchant, what steps do you typically take to manage cardiomyopathy? And at what age do you typically start this management?
So from a cardiomyopathy perspective, when you're in a multidisciplinary clinic, you're being followed very closely and being evaluated every 6 months to a year to make sure that there isn't any progression. And starting the medication earlier does help improve, because even for the less severe form of Duchenne muscular dystrophy, which is Becker's, they also have cardiac manifestations, and that sometimes is more severe than compared to their mobility that we were worried about. And so it's really important that we have them following with the cardiologist and the pulmonologist to make sure that we're doing the appropriate management from that perspective. And then I think the one thing we always forget is really the orthopedic management and the endocrine from a side effects profile. I feel like if we think about all the side effects of steroids, we can manage those appropriately if we're looking for them and we are discussing them with the families. So having that discussion early on, but all of these manifestations are really important. So I also hope that the family is an advocate for their child, saying, did we address this? Did we look into this? Or I have questions regarding my son's been having back pain, or do we have, is there anything we need to do for their bone health and maybe give treatment for that? So from that perspective, I think it's important when we're talking about that they're being followed for every single thing. And I think having all the disciplines makes a huge difference.
And to that point, with the bone health, that's an important part of their overall management. Aside from just the medical management, what's the role of nutrition in promoting their bone health?
Yeah. So I start that with really early on, since I'm an endocrinologist, and one of the reasons I went into that was because I want to make sure I can maximize their bone health and delay their risk of fractures. And so making sure they're having a good amount of calcium in their diet, making sure they have enough vitamin D in their diet. Sometimes we have to give them a little bit more of vitamin D supplementation because the steroids can affect that a little bit. And then their activity, trying to see what we can do to make sure that they're less at risk for fractures. But if they do develop fractures, we do have bisphosphonates. There have been lots of studies been done. It's been used for many years for patients. It's been done a lot more in the adult population, but it's really a standard of care for patients with Duchenne muscular dystrophy. So and it does improve their quality of life. And that's one of the things I do. Let the families decide when and if we want to start it. And sometimes we start it, there's some studies showing maybe we can even start earlier than we used to before.
That's great. And then just from a different modality regarding their lung function, Dr. Kuntz, how do you monitor respiratory function in patients? And What techniques do you recommend to promote their respiratory function?
We include guidance for respiratory care from a very early age before the boys are really having any major symptoms or problems. The first thing we try to do is include guidance and advice about cough assist. There's a very simple device. It's just a pressure device. Some people call it insufflator, exsufflator, but it kind of puts in a big pressure and brings it back to help with mucus release from the walls of the bronchioles. And many times introducing that so it's not a foreign procedure to young boys with Duchenne helps them through intercurrent respiratory illnesses so that they don't either get pneumonia or need to be hospitalized. So cough assist is one of the things that we do. And then after that, we just monitor them with their symptoms and with their peak forces, kind of pulmonary functions. And if they start showing a decline in their peak force pulmonary function when they come in for clinic evaluation, or if they begin complaining of tiredness in the morning or a headache when they wake up, suggesting that they may be retaining a little bit of CO2 due to some hypoventilation overnight, then we get an overnight sleep study. And the overnight sleep study helps us. Sometimes we're now able to get a transcutaneous PCO2 monitoring even in clinic to help a little bit with that. But usually if there's a problem, we see it first at night because everyone has a little bit less deep breathing during sleep, so that nocturnal hypoventilation will show up with morning headaches and grogginess. And then mask ventilation and positive pressure in a bi-pressure or BiPAP level is something that has made a really big difference in terms of energy and decreasing heart strain, and again has been a big move forward in terms of health outcomes for boys with Duchenne.
Okay, so the proactive symptom-based multidisciplinary team management and access to non-invasive ventilation have enabled patients improved survival into adulthood. What does the structure of this multidisciplinary care team for the optimal management of patients with DMD look like? Dr. Merchant.
I think one of the important things is having a great primary care doctor to make sure that they're following up with that, right? And so we need to make sure they're vaccinated and making sure they're getting everything else is being done. So a really good PCP. And then also, I think having emergency care. So like they need to have a letter maybe that says that they have adrenal insufficiency if they show up to the ER, if they have a fracture, to make sure that they mobilize earlier so they don't have those complications. And then there's the multidisciplinary clinic that we think of. And in every location, it's a little bit hospital and maybe slightly different, with which disciplines are there at that clinic. So obviously the neurologist, sometimes there's a genetic counselor, so to kind of help with the family with the diagnosis, and then GI, cardiology, endocrine, orthopedics, pulmonology. All of these are different components that are really important in a multidisciplinary clinic. It would be ideal if we could have everybody there at the same clinic every time, but obviously we all know it doesn't always happen. But I think the goal is that even if the child is not being managed by an endocrinologist, for example, they are being seen by them maybe, or having some communication to make sure that is being checked off. So I think that having all these does make a huge difference, because we not only, the reason kids are living longer now, also care has improved, but we've been able to coordinate care and everybody's wearing their hat to make sure that every component of their child's life has been taken care of. And so I think the multidisciplinary team needs to communicate. That's the most important thing. And I think that it could be a virtual model. It could be in person, which is obviously the best. But, we've all learned through COVID that sometimes things are a little bit different.
Sure. No, this is really great. It's important as a general pediatrician just to have all these different modalities in mind as far as managing these patients. But thank you for both Dr. Kuntz and Dr. Merchant for this interesting discussion. And thank you to the audience for listening.
Hello, my name is Dr. Nadia Merchant. I am a geneticist and endocrinologist at Children's National Hospital in Washington, D.C. I am joined today by Dr. Kuntz, a professor of pediatrics and neurology at Northwestern University, in Chicago. It's great to have you here today.
Hello.
In this section, we will consider the question, what novel pharmacological and gene therapies are available or emerging for the management of DMD? So genetic testing for Duchenne muscular dystrophy is very important because I think as the emerging treatments are coming, a lot of them are targeted to specific variants that exist. So I know there's a few that have been approved specifically for antisense oligonucleotides for exon skipping therapies. Can you explain a little bit what those are and how they're being used?
Nadia, you make such a good point about knowing the exact mutation of the dystrophin gene because many, if not most of these disease-modifying therapies have to be selected specifically to suit the individual's mutation. So with exon skipping, the intent is to take out another deletion, to carve out another piece of the gene so that instead of failing to read through or produce any protein, it reads through again with that additional deletion and produces a smaller protein, but smaller protein's better than none. So the first, and we now have 4 different, in the United States, FDA approved, and approved also in the European Union, I understand, agents that serve a fraction of the children with Duchenne. So the studies all started with medications that were administered intravenously once a week and have to keep up that therapy to have benefit. But the first ones were amenable to exon 51 skipping. So there are a number of different kinds of mutations that if you add in or take out the additional exon 51, that they will become a read-through so that they can produce some protein. This is eteplirsen, and it's now commercially approved. This is pertinent to about 13 or 14% of individuals with Duchenne. Then scientists just moved on and found the next exon skipping agent that would affect the next largest group of boys with Duchenne. One very effective one is exon 45, and that's been named casimersen. And that helps about 8% additional types of mutation. Again, it's not a single mutation, but a group that benefits from the addition of exon 45 to the current deletion. And then finally, there have been trials for exon 53, which adding that in as a skip benefits another 8% of the boys with Duchenne. And there have been 2 separate approaches to that by different scientific groups, golodirsen and viltolarsen. Both of those benefit boys where exon 53 skip will bring them back into reading frame. But the important thing is that each of these agents will not help all individuals with Duchenne, just the boys who have the kind of mutation or the group of mutations that if you add on just a little bit more out of the picture, that they'll go back from out of frame to in frame.
So I think that leads me to the next kind of group that I think about is like the synthetic steroid, like vamorolone that's come about and, currently being studied, because that applies to like more generally the population with everybody with DMD versus, and we could use it instead of prednisone, maybe a deflazacort, if it is as promising as some of us think it will be.
Right.
And then there's also the other category, I think that's currently being as a monoclonal antibody that's also being studied. And so that's something that I also am thinking of, which may be more generalized for the population. That's pamrevlumab, I believe. And then let's go on a little bit more on the genetics specifically, because I find those exciting. So the exon skipping, there's also the stop codon read-through therapy that's been, I believe, approved in some places. Can you tell me a little bit about that one?
Well, again, some of the mutations that occur in the dystrophin gene or any gene create a false stop so that the protein reading is terminated and there's no effective protein produced. And so not just with Duchenne, but in any situations where there's a stop codon, there have been agents developed that kind of power a read-through in that circumstance. The current one that has been most effective as an oral agent taken daily is atalurin. Now, this has been in clinical trial for a number of years in the US and Europe. It is currently approved in Europe, but it has not yet been acted on in the United States, so it's not available.
And then I think the other one that everybody's always talking about is gene replacement therapy, the magic cure. But what do you think about it? I know we're still a ways to go especially for almost everybody with Duchenne, but what are your thoughts on that?
Well, first off, gene replacement therapy is a new protocol, a new technique in humans, and there's a lot to learn. And we understand and anticipate some of the side effects by pre-treating individuals with daily oral steroids. Even the boys who are already on steroids, their dose is increased prior to and for a number of weeks or months after the single infusion, IV infusion of gene replacement. So this is something where I feel very humbled, where we have to really acknowledge that we don't understand yet all of the impact, both in terms of efficacy and potential side effects. But with this, it is something very exciting and promising. The problem with the dystrophin gene is that it's very large, over 79 exons, and the volume, people know how to synthesize the entire gene, but it will not fit into the currently available viral vectors. So it cannot be given as an entire gene to replace the defective one. So right now, a number of scientific groups, I think the count is currently 5 around the world, have different theories about which portions of this very large dystrophin gene are the most critical to include. So they pick out, the N terminal and the C terminal and the other parts in between, and they get their ideas by testing in animal models as well as looking at natural mutations that occur in Becker muscular dystrophy. There are some individuals with relatively mild Becker muscular dystrophy who have very short dystrophin genes. And so many of the scientific groups have been imitating that. There are 2 limitations to gene therapy in addition to all of the unknowns about it. One is that it requires this viral vector, and there are a number of serotypes of adeno-associated virus that are being used right now. And if an individual has existing immunity to them, they cannot get 10 to the 14 copies of that antigen delivered IV. So the existing rate of immunity in the community varies in different communities and at different ages. But a study that was done in boys with Duchenne at the age where they would be eligible for gene replacement therapy showed that it was about 17%, I believe, somewhere less than 20%. So that well over 80%, between 80 and 90% of individuals were not in that study immune. But that is one limitation. The other limitation is that they are not currently testing or including in clinical trials individuals who have mutations in the first 18 exons, because there is some concern about not having had previous exposure to that part of the protein, creating increased possibility of immune reaction. We don't know if that will continue to be an issue or whether that will be surmounted. But with all of these, there have been a number of probably over 100 individuals treated with gene replacement therapy with the different approaches, at least 4 different approaches so far. And one of them is closer to has been submitted to the FDA, and we may hear within 2023 about that becoming commercially available. That's delandistrogene moxeparvovec, the one that has treated over 100 boys so far. There are a number of other scientific groups, Fortidistrogen, moxeparvovec, and then others that haven't been named from several other scientific groups that are in the pipeline, and that we will get a lot more information once there's more experience.
Yeah. And I believe there's some deaths that have been in severe side effects that have been reported in some of the cases too. So I think that's also what makes everybody a little more cautious.
Mm-hmm. Yeah, there have been a number of side effects, including some complement-mediated immune side effects with some of the therapies. And as you mentioned, there was one death.
Yes, I think this is very exciting times where we're starting to diagnose patients maybe with the newborn screen for the future, and then along with having more and more emerging treatments and maybe combination therapy that I think we can't really predict what's ahead for us. And we all hope that there's better treatments available for all these children. Well, it was great talking to you today, and I always learn more. And thank you.
Thank you.